Hello, and welcome to the Health Go Live webinar series. Today's episode is brought to you by your friends at Primary Care of America. We would like to remind you that the chat feature is available, so feel free to send in your questions for the panel throughout the discussion. Our speakers would love to hear from you. And with that, I will turn it over to our moderator, Dr. Eileen Barrett.
Hi, and welcome everyone. My name is Dr. Eileen Barrett. I'm the chair of the American College of Physicians Board of Regents, and I'll be serving as the moderator for today's session. ACP, which is the acronym for the American College of Physicians, is a founding member of Primary Care for America. And that Primary Care for America is a diverse collaboration of key partners who are focusing on educating policymakers and health policy influencers about the value of comprehensive, continuous, and coordinated primary care. Its formation serves as a commitment to our continued effort to help improve the well-being of the individuals, the families, and the communities that we proudly serve. I'm joined today by two health innovators, Dr. Kina Fang, who's the CEO and co-founder of Elation Health, and also Dr. Christopher Crow, who is CEO of Catalyst Health, and they'll be discussing how today's models are revolutionizing the primary care experience. To start, I would like to everyone to get to know each other a little bit more, and you'll notice that we'll be referring to each other by our first names. And I'll ask if our panelists, if you could tell us a bit about your journey to transforming primary care in the country, and maybe Kina, would you start?
Yeah, absolutely. Thanks so much, Eileen. It's a pleasure to be here, and thanks to the health team and Primary Care for America for organizing. My journey to primary care. So obviously, as you mentioned, I'm today CEO and co-founder of Elation Health. We are a technology platform purpose-built for high-value primary care. So doctors use our technology to deliver highest quality care to more than 12 million patients across the country. And my own background, just in a brief nutshell, as a kid, I started working in my dad's practice as a teenager, helped him actually build it from scratch. And eventually, about a decade later, after I'd gone on to do different things professionally, was back in the practice and thinking about how to move his practice from paper to digital. And that led me down the path today. But I would say my formative years were really, in the practice, on the front lines, working in a primary care clinic where, it was deeply embedded in the community. There were deep personal relationships between the patient community and the physicians. And, I could really see firsthand how much that trusted relationship mattered in driving outcomes and satisfaction for the patient through their journey. So that's a bit of my path here today.
Wonderful. And I particularly loved hearing there were deep personal relationships. That's really lovely, because that's also why we're here, right? So all of us, right? And Chris, would love to hear from you.
So I'm a family physician by training. I haven't actually seen patients in quite some time, kind of pulling up on a decade, but I did about 10, 12 years of that with a practice that I grew and built, and is still part of our Catalyst Health network. My background, though, I grew up in a small town in Hillsborough, Texas, which had about 7,000 people and 3 doctors. And those 3 doctors were the mayor and the head of the city council and the head of the Methodist and the Baptist and the Presbyterian church. And, on the sidelines for every football game that the whole town went to. And so this idea of population health in the 70s didn't have a term, but I could see it in my own community because they were very visible way outside of the exam room. And so as I embarked on my journey to want to be a family physician, because those were such mentors and role models to want to be like, I took that path. And then, you get into the big city and you try to translate what you saw growing up into, how could you help communities thrive the way they did? And so certainly it seems like a great opportunity for a career or a life to try to help get the most out of primary care, because I've seen firsthand growing up what it can do to a community. And I think we're way underutilized. And I think we're going to be talking about that today, about the ways we think about that to unleash the power of that for every American.
Wonderful. And of course, thank you both so much. And hearing your different perspectives, it reminds us of how we all need to be all in on advancing primary care. And yet we also know that that the US is really struggling with that. And now the US spends considerably more on healthcare per person than any other developed nation, but our outcomes lag despite this. So Kina, I wonder if you would share with us, what are the major challenges contributing to this discrepancy? And with all of your background, your expertise, how do you believe that primary care can help address these challenges?
Yeah, absolutely. I mean, it all boils down to where we invest our healthcare dollars, and really in my view, the economics of our healthcare system. And for what it's worth, I'm somewhat biased. I was an economics professor prior to starting Elation, but from what I've seen, and what we all see, I'm sure, is we have a very top-heavy system built on this transaction-based fee-for-service revenue chassis, and a third-party payer system, and we know from other developed countries with much better health outcomes that primary care is such a key component of their success. We spend only 5 to 7% of our healthcare dollar on primary care, even though it's really one of the best investments we can make. We've shown time and time again that there's incredible return on investment for an incremental dollar in primary care. I mean, there's a study that shows an incremental dollar of primary care saves $13 in downstream spend. Yet knowing this, I mean, that's not new information. We've known that for a couple decades. The transactional way in which we pay for healthcare has really eroded our ability to effectively deliver primary care. And obviously complicating that is the fact that we have much less investment in our social infrastructure than a lot of our peer nations. We have a lot of variation and inequities across how health is treated. I think your health is more influenced by your zip code, by your genetic code in a lot of ways. And coming back to primary care, it's really one of the key levers we have to prevent through early detection, better condition management. And if we had this stronger foundation of primary care in this country, which I believe we can, and I believe we are all a part of building, if every person could have comprehensive relationship-based proactive care and a trusted relationship with a PCP or a PCP team, I think it would drive phenomenal changes and results. So I think it all starts with how we invest and pay for care.
Yeah. And I thought that the way you wrap that up, that it really does boil down to where we invest, and where we choose to invest is going to be such an important takeaway here. And I heard you talk about the delivery of primary care, and of course there can be lots of different models for that, and that can look like many things, and not all of us know what those can be. I wonder, Chris, would you be able to help us better develop a shared mental model for what are the types of models that are available that fall underneath the umbrella of primary care?
Oh, sure. The one of the great things of being a capitalist country is we have a history of innovation in solving big issues, and so I think the fundamental structure of how we built our health system that Kina talked about, being fee for service and transaction, probably coming out of the battlefields and helping people at big hospitals to start, was how we ended up in this fee for service. And the question is the outcomes we're getting now and the costs we're paying for them don't match. And so there's all kinds of actual really exciting and fun iterations of, whether you call it value-based care, direct primary care, of course you've heard of concierge care, ACO models. There's just a myriad of those out there because it's such a problem. When America sees a problem, we have a lot of entrepreneurs and smart people who try to go solve that. Now the cement of the status quo of our fee-for-service system is really hard to break up, but there's a lot of different things going on, but they're all kind of in a couple of main threads that really put the patient first versus the patient comes to the healthcare provider, to wherever they are, and care is delivered in a transaction, versus care anywhere, wherever the patient is, whatever they need at the appropriate time. So that's one thread. And then the other thread is really around payment differentials, more around what I think is more approachable for the lay people in healthcare to think about versus fee-for-service transactions, like when you go get your oil changed, to more of a subscription-based model, like everyone's familiar with Netflix and et cetera now, because we're all have a million subscriptions. Is how do you think about primary care as a subscription? Because very different than getting a knee replacement or having a hospital visit that is a transaction for a very short period of time. The value of primary care compounds over time, relationally, just like your interest compounds. Relationships compound over time because trust is built, and therefore behavioral economics can come into play in different ways with those relationships. And so this idea of paying with a subscription over time for that value compounding makes a lot more sense for how care is delivered at the primary care level. So you're seeing this combination of how it's being paid from transactional to relational subscription, and where it's being delivered, not just the physician office, but let's say everywhere, is where the models are all testing. And quite frankly, the government has led the way, but you're seeing quite a few entrepreneurial companies, a lot of them work with Elation, in fact, trying to find different ways. And the answer is we're too big of a country and we're way diverse to be able to have one way. And so we need a lot of different models.
Yeah, and I heard you mention at the end that you said that these solutions can be really diverse, and of course that the different patients in different settings will have different needs based off of individual and group characteristics as well as their preferences. And I wonder if you could talk about additional, or if also we could, and we'll ask Kina this also too, is what strategies do you see are presently in use to make sure that these diverse primary care models are accessible and also beneficial for a diverse patient population?
Kina, you want to go? Or you want me to go?
Oh, go ahead.
Maybe Chris. Okay, then Kina, you go. Okay.
Chris, go ahead, and I'll follow.
Okay, I think it's really simple. It's around, again, we're a capitalist country, and so it's around incentives. And so where you're seeing the government really step up, because they pay for so much of our healthcare in this country, whether it be Medicare or Medicaid, they're appropriately forcing these models and rewarding providers, or companies of different types to go to places that are, you say diversity, but where there's health inequities. I often call them healthcare deserts. So especially in Medicaid, where that's almost the status quo of the patient population. So lots of things happening that the government has done with CMMI over the last 10 years, 15 years, we certainly commend them for. And as those things proliferate, it starts to open up the creative engine of American ingenuity for entrepreneurs in the private sector to go take those models and look for opportunities, especially with this, the millennials get a lot of slack sometimes, but they care differently than maybe Gen X that I'm in, or certainly the baby boomers, not more or less, just differently. And so some of the ways they care broadly, combined with these models, has really, I find, accelerating some really exciting things companies trying to do to really say, I'm only working on the most difficult patients who are in the most in need. And quite frankly, that's where the best value is. Providing healthcare for healthy 25-year-olds doesn't have much of a return in any near term, in most cases. Not that there's not a business model for that too, but the ones that really need it is where we are seeing the government focus, and you're seeing some private equity and venture capital follow.
Yeah, one of the points you made, Chris, that I really loved is that point you made about moving to more of a subscription model, because the default in a subscription model is that the relationship is ongoing, that it is going to recur, it's going to happen again. Whereas I think traditionally a lot of interaction with primary care has been, okay, I see somebody, am I going to see them again? Am I going to see them next year? Like, who knows, maybe, right? And I think that's what breaks a lot of, or limits the potential. And so I really love that comment you made. And then, going, to your points around where a lot of the innovation is happening, I think you're exactly right. Is it's really happening in the places that need it the most, and also that are the hardest, right? And so there are really great entrepreneurs, fascinating companies, and real incentives and dollars being put by the government behind moving to these high value primary care models that are caring for more vulnerable populations and really tackling places where costs are soaring unnecessarily in a lot of ways. And the really unfortunate thing is these soaring costs correlate to really poor and unfortunate health outcomes and health events that can be prevented, if they were identified upstream. And one of the things I wanted to emphasize as well, and I think Chris alluded to this too, is where and how care is being delivered. And there are these innovative companies showing up that are able to now target very specific populations that are historically underserved, in part because of the innovation in delivery models, virtual care, telehealth, ways that you can actually get to patients and get to a critical mass without all of them having to be in the one region where you could sustain, a particular clinic or set of providers to be able to build a business model like that. So I think it's, I think we're going to be seeing a lot of innovation where we have been, and we will continue to. And I think that will really benefit, especially these more underserved populations where there's so much potential and have historically, not had a great experience.
I heard there that one of the things that an example that you provided was about how technology has stepped in. And thank you for sharing that example for us and talking about the role of these people can be geographically diverse settings, and yet there can be this innovation that is happening anyway, and by leveraging technology. I wonder if Chris, if you also would be able to share how you've seen how technology is driving success in this sort of value-based world that we're living in, and any specific examples if you have any.
Yeah, sure. And I'll actually, looks like John Ziegler put a question about subscription payments versus capitated payments, and I can actually connect that to this answer about how I think about technology, because I think the economic model drives your operational model, and therefore the technology that you would consider is different. And so I sometimes say subscription for capitated as well. There, you could argue there's a little variation, but I think people understand subscription and they don't necessarily know what capitated means. And if you say capitated to people that are over 50, they freak out. And I'm over 50. So I use subscription because it's such a broad-based business model that, like, my teenagers, when I tell them about fee-for-service versus subscription, they ask me, why in the world would anybody have a fee-for-service model? I'm like, right. But the world has been this way for so long, and they're like, that just makes no sense. Like, right, you're about to walk into this world. Maybe you can go in and fix it for us. So the technology, when you move to the technology for fee-for-service, is just what can it do to help you do more? I mean, Kina built Elation, and one of the things she had to do was just help her dad just get through the day with seeing all the people that he needed to see, which was on a fee-for-service chassis. And then obviously she's evolving that model in the way, but that's the way all the EMRs worked. Was only, it's a bill, help to get you faster billing system for your fee-for-service transactions. When you move into this new idea of a relationship payment over time, and your goals are not to see how many people you could see that day, but see how many you can take care of effectively with outcomes that ultimately yield to better health and lower costs, and of which case you would probably be aligned with, then again, that makes the care everywhere come online. In a fee-for-service world, you can't do care everywhere. You got it. The telehealth helped a little bit, but it doesn't necessarily. There's not, one of the reasons palliative care hasn't taken off in this country, and that, we spend so much at the end of life, is because it's hard to have a primary care provider, a doctor, a nurse practitioner, drive to someone's house for $150 all day, every day for about 4 or 5 people. It's awesome care, but it's not paid for in an impactful way. And so technology that we have today, like this right here, we're doing right now, I see Eileen and kind of on my stream, that could easily be, my patient and their daughter that lives in Florida, as well as their caregiver who's in another room. I mean, we could have a lot of things going on in a very short period of time. Imagine trying to do that inside my office. People have to fly in, we have to get into our Ubers. If we have that, we have to drive. Mom doesn't ambulate very well. She's on a walker, she's in a wheelchair. So all of these things, when you get in a subscription model, the technology it's not whiz bang stuff. It's stuff you use every single day to live your life. We're just applying it now because there's actually an economic model to allow you to use it. So I gave you a little bit example. Again, it's not, I mean, we can talk about AI. That's going to change our world in a lot of different ways. But we haven't even unleashed the technology that started in 2000, into this world yet because of the fee-for-service economic construct for most of healthcare delivery.
Yeah, so of course there's so much potential, and I was struck by the example that you said about palliative care and the barriers and also the facilitators, and also the way palliative care, I feel like, is one of the examples that has been able to take off because there was the need for it. There also were the passionate, well-trained people who pushed for it, and also the patients engaging with it, and that there's so many other models and so many other examples of how meeting the patients where they are and having that patient engagement is going to be so transformative. I wonder if, Kina, are you able to share any examples about where also how patient engagement really changed the outcome or the direction of a primary care model?
Oh, absolutely. I mean, I think that is one of the huge opportunities for unlock in a more, value-oriented primary care, delivery model, because, at the end of the day, the patient is an incredibly instrumental actor and participant and in primary care, and they, in a lot of senses, they are part of the care team, especially their family members, caregivers, et cetera. And I totally agree, Chris, that technology is part of the operational infrastructure that's downstream from the incentives. That's a lot of the reason the technology today is just so at odds with the care, supporting the type of care and high quality care that we want to see. A big part of that is because the EHR systems were not incentivized to do that. They were incentivized to pump out bills and create documentation to support bills. And that's what, legacy EHRs are really built around. And coming back to the point about patients, to the extent that they can have that connectivity, be on the same page, understand the care plan, follow through on the parts of the care plan as a team that they're responsible for in the same ways that the clinicians are responsible for. I think there's a lot of power in that, and it returns power to the patient as well. Makes them feel more informed, makes them feel like they have an active voice and an active role to play, which they absolutely do. I mean, I often talk about how this may be a little too simplified, but for a physician, especially a primary care physician, a lot of what they do with a patient in a visit is just describe wishes of what they want the patient to do when they walk out the door. It's like, I want you, I wish for you to go get this prescription, not only get it, go to the pharmacy, get the prescription filled, but take it over this, usually, for some amount of time, according to these directions and so forth. There, whether to get this referral, get this lab, et cetera. These are wishes you're asking for the patient. So inherently, healthcare is a team between the clinician and the patient. And I think technology can help make that teamwork more effective, more transparent, more coordinated.
Yeah. And you have, of course, said so much there, because I heard you both describe and either explicitly and also alluding to what is the role of the public policy, and then also you just concluded on team-based care, and then again it's about the payment landscape also too, and I'd like us to come back to all of those. I wonder if can reflect on that. Many of the primary care models are shifting the payment landscape. Many of the primary care models are shifting the payment landscape the way you have just described, and in that wishing to reward value and to better again, to align those incentives. So I wonder if you would be able to share your thoughts and your opinions even further about which of the payment structures you think are effective and where you think there might be some room for improvement. We can go a little bit more into that.
Is that for me?
For you, and then also then to Chris. Yeah.
Okay. So we've talked a lot. I think broadly speaking, right? There's fee for service and then value-based, right, payment structures. And I guess for Chris, you talk about that second category as subscription, which I like the neutrality of that, because value-based care is just this, ever encompassing like concept that continues to grow in terms of what specifically, in terms of what it actually refers to. But I mean, I think obviously the fee-for-service volume-driven model does not incentivize the type of care, especially primary care, that we want to see, and we've talked about that quite a bit already. I think as it relates to more value-based models or subscription models or models that are intended to align with value, I think that's where we want to focus. But I do think on the practical end today, in a lot of the implementations of these value-based payment models, one of the big challenges is, it introduces its whole own new set of administrative overheads to the practices that are participating. I'd say on two fronts. Like first, very few providers can switch to value-based care from fee-for-service in a binary way. It's not like, January 1st, 1 year, suddenly they're 100%, value-based and 0% fee-for-service. Some organizations have been able to do that, or they set up clinics de novo. They are 100%. And I think there's huge value and advantage in doing that, but that's just not the scalable model for how we move the whole country, right, to value-based care. And so I think the challenge in having to have a foot in both worlds is that you have the administrative overhead of the old system, and then you get the new overhead of the new system, which is asking you to code in different ways to, focus even more on diagnosis codes in ways that you haven't before, to really, document clinically in ways that you haven't been asked to before. And so that type of dual overhead, I think, is a big challenge. And it's something that we think a lot about in terms of how do we make our technology such that we can reduce that administrative overhead so that those who are stuck with one foot in both worlds, as many will have to be, can lighten that load. So that's, I think, one challenge. And I think, the second challenge is that it's, as you can see in the evolving evolving ACO models and Medicare Advantage rules, that CMS and CMMI are driving forward, there is a lot of challenge to really get providers focused on actually driving outcomes and reducing total costs of care, because there's a lot that can be done, more so on the top line and on the risk adjustment front or other fronts that aren't necessarily moving outcomes and costs. So I think there are a lot of details that we need to iterate on, continue to improve on as it relates to payment models, but I think we're headed in the right direction.
Thanks, Chris.
I kind of think of it fairly simply that primary care physicians over and over have shown that if you have a longitudinal relationship with a patient, that you live longer, you cost less, and you have more good days than bad. The government has way more incentive starting at age 65 or at Medicaid to take a long view, like a longitudinal relationship with the PCP has, and invest in that. And you've seen that for years, and they try a lot of different things. And there's been a lot of success and a lot of failure in that, but mostly a lot of learning in that. And we can see that these truths keep getting proven out in a lot of these different ways. Nothing pure, no silver bullet. The Medicare Advantage world, where you can take full risk, or the ACO REACH programs where you take full risk, some of the advanced MSSPs, I think it starts to allow that relationship to get the power of that compounding, and all the technology things come with in that subscription. So you don't have to think about, do Do I have telemedicine? There's a bunch of questions in here about, do you do remote monitoring? It will tell, all of that becomes like table stakes type of things for us when I'm taking care of a population at full risk. That's half the country. And I think we're moving in a decent direction there. The other half of the country, where most people are getting their insurance through the employer-based model, is where we have real trouble. Number one, you have a disconnect because most employers aren't even in healthcare, yet they're providing healthcare benefits, so they don't even understand it. Secondly, you have turnover. Employees today are staying on the average like 2.5 years. So there's not a lot of investment like you can on over 65. And of course, we all know the transparency difficulties in the games that are played. And so this being able to take on a population under 65 or not Medicaid in the employer sponsored model is really difficult. I don't have the answers. All I can tell you is that the problems are right there. They're right there, in that you have quick turnover of employees, so you don't have a long-term view. You don't have a day-to-day concern about healthcare in most businesses. And so you don't have the incentives built to do anything more than the status quo, which continues to consolidate power with, whether it's a health insurance company or a local hospital system or pharma. So it's really hard. And so a lot of where I would love to see is, can we create more public-private partnerships to take what we've learned on the longitudinal, and how do we think about that on the employer model, and how do we even think outside the employer model? There's plenty of concierge has been out there for a while, but how do you take that concierge to the common man? The ACO models kind of dip their toe in that, but it's really, really difficult. So I'm not giving you all the solutions, but I can tell you like exactly where the pinch points are that make it really hard to take what we're doing in Medicare, because the structure of the commercial market is different.
Yeah, just to chime in, we've mentioned the concierge model. It's worth mentioning the direct primary care movement, right? Which is targeted towards this commercial, employer segment that you're mentioning, where, unlike concierge, it's intended to be a much more affordable price point, but an opportunity to have it's actually exactly marketed as a subscription, subscription to a direct primary care practice and a primary care physician that is there for you to take care of you, and when the needs arise. And I think that has been very successful. We serve many of the direct primary care practices, and it certainly haven't spoken too much about burnout and workforce challenges, but it has been an outlet for many primary care physicians to find joy in their practice again, and an opportunity to actually connect with patients. I mean, obviously at scale, patients paying, a few to several $100s a year is not necessarily an achievable thing, for everyone. And so finding ways to, I think, leverage learnings from the DPC model, and a lot of those models are scaling into employers. I think there's a lot of possibility and opportunity there. And in some cases, we're seeing that converge into some of the value-based kind of capitated contracts when those relationships get larger. So I agree with you that that's an area that has a lot of challenge. And but as you mentioned before, in our capitalist system has allowed for many different innovative models to be tested. And they're out there seeing some levels of traction.
I really appreciate you highlighting that where this ended up going was talking about the workforce and taking care of the workforce, and the issue of that so many people go into a different model to provide the type of care that they wish to receive themselves, of course, and that there are going to be a lot of public policy decisions that can affect one's burnout, as you mentioned, and also their joy in medicine, their administrative burdens, and their connectivity with their patients, their ability to be true to themselves. And I did hear Chris say, like, well, I don't have all the answers. Well, we don't have to have all the answers, of course, but you certainly have a lot of them. And I'd love to hear from both of you that if I mean, if you're in the position to recommend changes or enhancements to our current policies, what would be your top suggestions to fortify the effectiveness of primary care so that we can have those those relationships, right, and have those outcomes that in the beginning we talked about? The healthcare outcomes are better with primary care. It's also better economically. So it's better for the patients and it's better for the economy. So there's a lot that needs to be done here, and a lot that's thus far undervalued. What would be, within that context and your expertise and your lived experience, what policy changes would you recommend? We'd love to hear from both of you.
I mean, what comes up in me is just how bitterly divided our country is around politics. It's hard for me to imagine some things because we've managed to polarize everything. And so, but let's pretend that wasn't the case. I think there's some things around, having, take direct primary care, for example, which has its burgeoning effects that I like as well. Like, state by state, there's laws around, what's considered insurance, and therefore what do you have to have from reserve standpoint that you could probably lean in on. There's issues about, you can deduct your healthcare costs from your business, but not necessarily personally from a standpoint, outside of your HSA. But if you could do some different things around, how to equalize the tax deduction opportunity for healthcare at the individual level, there's certainly that. There's some states have just pegged, and countries have pegged, a certain amount of investment required into primary care. That's a very blunt instrument that, again, going back to polarization, I live in a state where that wouldn't fly. There's a lot of transparency, things that have started to open up a little bit, that there's potential there. So there's a lot of edges. The macro is that, going back to what you said, if we want outcomes that make people healthier, and therefore we have more dollars to spend outside of healthcare on other things in the world, like infrastructure and education, and things like that we're not wasting in healthcare because we're in this fee for service model. It all comes back to incentivizing payments, which gets back to the economic models. And so again, the how do we get the commercial carriers, ironically, the BUCAs of the world, do the full risk, full capitation things, subscription models on the Medicare Advantage side, but they don't do it as often on the commercial side. So really kind of pushing that more as a requirement. But I fight this in my own state with my own physicians, my own Texas State Medical Association, and things that drives me insane. So the polarization makes it hard, but those are a few that just come to mind. Probably list 10 more, but I'll let Keena go.
Yeah, those are fantastic, and I love the focus on the economic aspects of that, and the tax ones. I would have to plus one. How much of the healthcare system and the challenges we see are the result of just tax laws, tax imbalances. What is tax? What is not? I think if I were to throw a few out there, I think one of the biggest challenges we have with primary care is that it just is not financially attractive today to physicians to be in primary care, and that is changing with it's a lot of the intent of these value-based models is to try to get primary care actually, I would call it just paid their fair share, right? If they can drive an incremental $1 of primary care spend reduces $13 in downstream medical expense, they deserve a part of that. And so I think ways to make primary care more financially attractive beyond that's a very downstream way to do it, these value-based payment programs, and primary care docs can make more. But what can we do about incentivizing new grads to become part of the primary care workforce? I think there's anything from student loan forgiveness, our visa policies, incentivizing new graduates who do go into primary care, who work in underserved communities. I think there's a lot of power in that. When you speak to new grads, they have these existing preconceptions that's it's not a specialty they can go in to have a sustainable, lifestyle and be able to do what they want to do. And I think a lot of that is changing, and I think being more proactive about that and having policies that make it financially attractive are well worth investing in. So, there's other things like the, I think there's small things that are not small, but, other things that are happening like that are positive that I'm encouraged by. Medicare's G2211 complexity code is great. I think a lot of things that we're seeing in CMMI's making care primary program are really positive, that show learnings from CPC, all the different programs that preceded it. But yeah, those are some of the things that come to mind for me.
I love hearing some of those tactical examples because of, and that it sounds like that they're occurring at multiple levels, because I heard you talk about things that can be policy at the federal level, but then also we heard about things at the state, but then also some employers are doing some of these as well, related to, you mentioned the example of loan repayment, and then also the bigger issue is, not the bigger issue, there's so many bigger issues, but I really appreciate you talking about the real need that we have to, that is the way a capitalist system works, right? Is that we need to pay people what they're worth, and what the work is worth. And I think that might be one of the challenges of when we talk about value-based care, is that some people feel maybe that they aren't valued, and that can be the downstream consequence, right? Yeah. I wonder if I heard Chris also speak about how there are some states who are doing some things that are innovative. I didn't know if there were, like we heard from Kina, some specific examples, and you described also that there was some heterogeneity that you had seen in what states are doing. Are there any others that you that have come to mind that you would wish us to know about? And I say this because we have this national audience, right? And so it might be that someone doesn't know that, one, that their state is doing it, or that the state next to it is. And this call is filled with leaders who could engage with that process with their employers, as employers themselves, as leaders. Anything else we should be thinking of from a policy perspective?
Is the question you want me to highlight some of the areas that's happens, or?
Yeah, thanks. Any bright spotting for
Okay.
any policy things
so,
that we haven't yet heard about?
Let's see, Kina, is your $1 to $13 the Rhode Island state thing? Oregon, right? So Oregon, there's Vermont, there's Rhode Island that have done things that they've tagged a certain amount of investment into primary care that all shown returns. And there's a Maryland there's a Maryland model that has done that as well. There's some other progressive states that are doing some things around all payer models, around being able to see to combine data across the state, to be able to look at things more broadly than that you could on your own, to be able to make better, so the state can then make better investments. Medicaid is done state by state. So depending on what your state you're in, there's different opportunities. There's a lot of requirements at certain state levels to invest in primary care, or they'll call it, value-based care requirements of a certain percentage of the population. So you kind of got to check your state by state to what those laws are. And every year it clicks along a little bit. But there hasn't been this massive shift across the country yet. Kenny, you may have more examples.
I think you covered a bunch of the ones that came to mind for me, and I mean, but it is a wonderful thing that at the state by state levels we can be experimenting, learning, seeing what works. Obviously, as Chris mentioned, many things come back down to politics, unfortunately, as it relates to just truly learning from each other's experiences. But, we can stay optimistic about overcoming those in the future. Yeah,
of course. And in the spirit of that type of optimism, what do you see could be the potential impact of some of the models when scaled in different ways, that this primary care transformation can have for the U.S. healthcare system?
Well, I mean, the impact is you get healthier citizenship at a lower cost, and you can choose to use your cost differently. You can use your dollars differently. So at the community level, you could invest more in roads and streets being fixed. You could invest more in firemen and police, and schools could invest more in after school programs and paying teachers a salary that include and helps our teachers want to become teachers, or young people want to become teachers. You could have philanthropy. People would have more in their pocket to be better at philanthropy, to give to those in need. I mean, we waste a crap ton of money. Let's be real about this. And like, what would you do if your GDP was not 20% healthcare and it was 12? What would you do with that 8% at the national level, at the state level, or at home? If I had 8% more, dollars that I'm not giving away to the healthcare system, what would that mean for especially that 8%? Usually at the lower the income level, that could be a much higher percentage. What does that mean for my kids and their ability to have clothes, have food, be able to, get them to school, get them to other after school programs, the opportunities that I can provide for them? I mean, it's massive. I mean, we don't realize that we actually fleece our communities with our healthcare spend, but we do. So the opportunity to really get around to get over on this particular topic to a better state is transformational.
Yeah, I could not agree more. I mean, the two massive wins are obviously financially, as Chris has mentioned. What we do with hundreds of billions of dollars more, whether we shave it off our national debt. I mean, so many ways we would use the additional money that's just being wasted today. And then a healthier citizenship. I mean, people, I think it is impossible to capture, what the benefits of that would be. But those are two huge, win-wins that can just come from a very simple, it's a very simple concept, which is let's just take care of people proactively in a preventative manner, in a holistic, comprehensive way, in the communities before, adverse things happen or develop. So those happen much less frequently.
I love that because it also is the meld of a very humanistic model with one that is economically makes sense, right? And believing in that population health, right? And we believe in the care of populations, just the way we heard in the beginning from both of you and from your different experiences with your dad and Christine, the mayor being being one of the physicians. So I feel like as we start to transition, you started to touch upon what would be, what could be unleashed. And I wonder if there's anything else that either of you wish to share about your blue sky thinking for the vision for the future of primary care, and any other thoughts about that?
I mean, I think my blue sky vision is very, very simplistic. It's just every person to have a PCP they know and trust. I think that, that is accessible, affordable, culturally appropriate. Like, I think it's a very simplistic idea in the end, but I think it would unlock a lot of what we've been talking about today. And, it's a complex path to get from here to there, but I think, that's what I think about, and I work towards in what we do every day.
What I would say to that is we actually started a little nonprofit for healthcare desert areas to take our virtual care model into places with community centers, churches, areas that have trust with the community that generally doesn't trust healthcare, because the only time they come across healthcare is in the emergency room. And then they get these crazy bills. And so they stay away from healthcare. And it's this virtuous negative cycle. Virtuous, that's not the right word. It's a negative downward cycle. And so for me, I think about in that particular not-for-profit, but I can take that to this broader question is that I hope a generation from now that we all have a way, and certainly with technology and payment models, because I don't think these payment models for physicians, the thing about DPC I don't like is it takes physicians out of the game for a lot of patients. Like maybe it's 500 patients, 700 patients. The matching doesn't work. We're not investing. We need more primary care physicians, it's a whole other policy thing we could talk about. But and team-based care monitor, nurse practitioners, PAs. I'm for all of the allied health pharmacists. Let's all find ways to work together to address our country's needs. And so the goal would be, can everyone have a primary care physician or access to a primary care physician the same way we have access to elementary schools, the same way we have access to water, clean water. Like, people get all freaked out when we start talking about rights. So I won't say whether it's a right or not. It's just, hey, let's just have a civilization here in America where that is something that we think is important, and we see the long-term value in the return it brings to our country, because it opens up more free cash flow dollars to invest in other things, and so that we invest in that way. So a generation from now, we don't have kids waking up every morning and not even knowing what the heck primary care physician is, maybe their entire life.
Yeah. And of course, thank you both so much, because it is optimistic, and it's also something that we can do. It is something that we can do. So with that, then, I really am just so grateful that you've shared these wonderful insights that are just so thoughtful and also inspired. And I think that your expertise, your lived experience, and your perspectives, they truly enrich, of course, all of our collective understanding of the evolving landscape of primary care. And I wonder if there's also, what you said did prompt a lot of questions in the chat. So I'm going to see if we can try to get some of those we were able to get to. Some of them, I think, we started to touch upon earlier. So maybe we'll go through a few. And I wonder if one thing, just very tactically, we heard about team-based care, and we also heard about virtual care. And I wonder if you can share any insights about how policy is changing to enable cross-state border telemedicine or telemedicine care. Are you able to speak to that, either of you?
That's not in my opinion.
No. Okay. Kina, is that one that's come up in your work?
I mean, policy is changing pretty rapidly around that, given the relaxations of policy that have happened over the COVID period. I mean, I wouldn't say I could speak to it definitively, but overall, the balance on each side is, on the one hand, people have seen tremendous value from enabling and relaxing cross-state and cross-border limitations on licensing, prescribing, et cetera. But on the flip side, there is a lot of concern about potential inappropriate use and inability to track what is happening across state lines effectively. And so those are sort of the two sides that are weighing against each other in the ongoing policy debates here. But that is an active area of policy debate and discussion today.
Yeah, and I think rapidly evolving, like you had identified. And for the person who had asked that if the American College of Physicians has stance on this, we have extensive policy advocating for having expanded patient-centered, clinician-centered, and effective telemedicine as well. There's also, I think that both of you would probably have a lot to say about recommendations for healthcare facilities. And I think by that we mean also employers and systems to address the stress and burnout among that the workforce is experiencing right now, or that much of the workforce, not everybody.
Yeah.
As it relates, sorry, the question was as it relates to this, the workforce burnout that's happening.
Yes.
Yeah.
It's a whole nother hour at least.
That's it. What I will say is it is an enormous challenge. We already had kind of workforce challenges, and burnout challenges pre-pandemic, and those have only obviously accelerated and gotten much more challenging and dire. And I mean, again, I think going back to, if you go at, you can find kind of these top reasons for burnout, right? Administrative overhead. A lot of people point to technology and EHRs, and there's kind of just overall, it's the complexity of just trying to do what's right for the patient. Like, I think a lot of the burnout simplifies down to that. And I don't know what fast solves there are, but I do think that one of the goals of moving towards these more sustainable, value-oriented payment models are to achieve, the quadruple aim, part of which is the burnout challenge. But I would acknowledge it as a big challenge that many healthcare providers, facilities, groups are facing. And actually, Chris, I'm sure you give this a lot of thought within your group as well.
In terms of burnout. Yeah.
Yeah, and workforce.
Yeah, I think the workforce thing that I would say real quickly is physicians get a lot of highlighted burnout. There's a lot of reasons why. We've talked about that already, but the employees inside the delivery system, from nurses, down to clerks and medical assistants and things like that, especially in that $15 to $20, $25 an hour range, those people who are really critical to care for, the caregivers at home, the people who are going into the home with hospice, home health. You're competing against Amazon, Uber for that talent level, and it's something that's not remote. Usually, you have to go in hand-to-hand combat, so to speak, and you have to put yourself in harm's way from a healthcare standpoint that we've just talked about lived through with COVID. So it's not just about the physicians. It's why technology and subscription payments play such an important role to help reduce burnout and really change how we do the workforce. Because if it's all personalized in the home, that's going to get really hard, because I don't know there's going to be tons of people signing up. And then you add in our immigration policies nationally, I don't know where they're going to come from. And so it's only going to get worse. And that's kind of the track we're on right now. So yeah, obviously I have a few things to say about that.
Yeah. And I know, actually, Chris, you referenced some of the whether we want to speak to AI during this conversation, but if we want to be very tactical about some of the burnout challenges too, I mentioned that technology often stands out in the top 3 causes of burnout. There's, I think, on the horizon there, at least on the clinician side, there can be a number of advancements there from a technology perspective that just relieve repetitive work that is draining when you feel like you're doing something over and over again that isn't really contributing to care.
Yeah, there is so much to be said there, and I appreciate you highlighting the role of technology and also the possibility if we use technology appropriately. I remember reading a paper, and then I decided to follow its advice. It was a journal article that was in the Journal of Hospital Medicine, where they trained in this case it was residents, they gave them a dedicated training in their EMR, and then they revised knowing that technology is so much more than that, but then they revised their templates and their order sets to be consistent with what their needs were. And on average, they finished their notes an hour and 20 minutes earlier every day. And their notes were deemed to be by independent observers of higher quality, also to be shorter, but again, to be finished earlier. So I say that to say that is just one little example of how the technology that is already in place can help make some changes for us. I remember also reading the statistic that it was a practice in Iowa that when they had added printers in every room in primary care, that people finished 30 minutes earlier. And so some of this technology is here and some of it is still emerging, right? Like you just mentioned AI, and we look to see how will we adopt it. There is so much more that could be said here, and I know I have learned so much. I wish that we weren't at the top of the hour so I could continue to ask you questions, and I hope that and I really truly want to thank you both for sharing your time, your insights, your expertise, and to thank our audience also for being so active in this conversation. I hope everybody's able to go a little bit deeper into this and explore the approaches through Primary Care for America and also the organizations, the constituent organizations in it. Please do, and thank you to the team at Health. I wish everybody the best. I hope that you can stay in touch, and thank you for doing the great work that you're doing, Kina and Chris.
Thank you to our speakers and to everyone that joined us today. Please visit our website at community.hlth.com to catch up on all Health Go Live webinars. And join us in Las Vegas, October 8th through 11th for Health 2023.